How to Diagnose Cervicogenic Dizziness with the Optimal Sequence Algorithm by Dr. Harrison Vaughan and Dr. Danielle Vaughan. We are going to take you through an introductory of what this book entails of how to properly diagnose cervicogenic dizziness. Our table of contents breaks down all our chapters, breaking you through the optimal sequence algorithm through our 16 chapters here to figure out the most appropriate direction of how to go about doing this condition. Our first chapter entails a lot of the background information on cervicogenic dizziness, how it's typically diagnosed, how common the diagnosis is, basically in the subcategories of the geriatric population, post-concussive syndrome, non-traumatic cervicogenic dizziness, and then other conditions of how common is it in the ENT world and how common is it in chiropractic care. We break down the differences between cervicogenic vertigo and cervicogenic dizziness. Take individuals through the timeline of the different definitions that help you better understand what cervicogenic dizziness is over a period of time. We go into great details of the controversy associated with this condition and the different opinions that are associated. This is our introductory section that will eventually lead to what we call our optimal sequence algorithm. Chapter 2 takes us through the purpose of the book and how to go through each of the algorithms so you eventually can come up with the diagnosis, which is a diagnosis of exclusion of the cervical spine as the source of your patient's cause of dizziness, lightheadedness, or unsteadiness. Chapter 3 takes us through our Appendix A, which is the cervical fracture. Each appendix is going to break down through physical examination tools and subjective examination tools. As you can see here, an example for Appendix A is using the Canadian C-spine rules to help make a differential diagnosis to rule out a fracture of the neck. The central disorders is a very in-depth chapter. This is our part 1 that breaks us through the steps necessary to make the most clinically informed decision to rule out central disorders. This chapter takes us through the beginning aspect of our algorithm, looking at at-risk patients and coming up with different information based off of the common causes of dizziness and the differential diagnosis of head and neck movements, differential diagnosis of cervicogenic dizziness, red flags, the 5 Ds, 3 Ns, and A, take you through the diagnosis of panic disorders, and even medications associated with dizziness that we just need to make sure we rule out before we go look at the neck. Central disorders has different chapters. This is part 2 in chapter 5. It helps us identify at-risk patients of orthostatic hypotension through causes of orthostatic hypotension and symptoms of orthostatic hypotension and presyncope. We even go through identifying at-risk patients through a physical examination. Central disorders continues with the part 4 aspect of looking at the cranial nerves. And we do a bottoms-up approach to examining cranial nerves, as you can see on the left side of our algorithm here, starting with the hypoglossal nerve and then going to the olfactory nerve. This chapter goes into details of how to properly investigate each one of these nerves. Central disorders continues in chapter 8 with our part 5, identifying oculomotor involvement through the physical examination. This just takes us through the right side of our algorithm here, looking at spontaneous, engaged, and holding nystagmus, and then examining more of the cranial nerve 2 with the optic nerve through the confrontation method, pupillary response, going into more details on the cranial nerves 5, 3, 4, and 6, including examining appropriately how to look at smooth pursuit and saccadic eye movements, and breaking down the cover-uncover tests, near-point vergence, head thrust tests, and the Hintz examination. Very detailed information in these chapters on essential disorders. After we rule out a central condition, we have to look into the cervical artery dysfunction. This is the part one of this examination, including what the algorithm that Dr. Harper and Dr. Vaughan did to really help break down the spontaneous versus mechanical aspect of why you need to make sure that a condition of dizziness is not a vascular event in process. Chapter 9 takes us through that details. Chapter 10 is part 2 for cervical artery dysfunction, and it helps us identify individuals who are at risk for cervical artery dissection, the symptoms associated with it, clinical features between internal carotid artery and vertebral artery dissections, and different clinical characteristics associated with dizziness from these conditions. We provide several tables and then how to perform a physical examination to make sure you are appropriate in ruling out the vascular system. Chapter 11 goes further to ruling out cervical myelopathy as a cause for unsteadiness and gait disturbances through our subjective and physical examination, including our algorithm in our Appendix D. Moving forward to Chapter 12 is how we rule out instability of the cervical spine as the reason for symptoms. We take you through our Appendix E, looking at subjective examination procedures of risk factors and symptoms associated with this condition, and take you through the most appropriate physical examination processes to rule it out. Going further, we look at ruling out peripheral conditions in our Appendix F. We really look at showing how we can make sure we rule out different canals to not only rule this out as something of not BPV in origin, or ruling it in as a double diagnosis, such as a double entity. We take you through the examination procedures associated with these conditions. In Chapter 14, we finally get to the cervical origin section. This is how we can start to rule in the cervical spine as a cause of cervicogenic dizziness. Part 1 takes us through the different subjective examination factors through several of our tables, looking at risk factors, common descriptive words that patients may have if it's coming from the cervical spine, specific symptoms, utilizing the dizziness handicap inventory as a diagnosis, and then different type of diagnostic criteria through the literature. The cervical origin part 2 is our chapter 15. This takes us through some of the physical findings you may identify with range of motion. It looks at identifying which joint is at fault for this condition, and then some specific tests such as the cervical flexion rotation test, including the metrics of this test, passive accessory joint palpation, and metrics for cervical spine orthokinematic evaluations. Chapter 6 goes into even more depth. This is our part 3 of cervical origin, taking us through cervical cephalic kinesthetic sensibility assessments to rule in the cervical spine as a source of dizziness. It is organized in the following manner, looking at cervical cephalic kinesthetic sensibility, introductory tests, joint position error testing, going into deep cervical flexor endurance testing, including the reliability and scores and all the metrics associated with these conditions. And we go further and further down the cervical extensor strength test, smooth pursuit, neck torsion test, head steadiness test, neck vibration test, upper cervical 2-point discrimination test with all the metrics associated with these conditions. That takes us to the end to figure out that this cervical spine could be the origin and help you appropriately lead to treatment of this condition. Our book ends with references broken down by each appendix, starting with different reviews and editorials that you might enjoy. Some of our top recommended readings on this condition. and then breaking down the evidence per each section that we have. Very detailed book. I hope you all enjoy it.